Good evening. I apologize for the brief hiccup at the beginning there. I am Art Vandenhouten. I am the Interim Vice President for Academic Affairs at Flagler College and the Interim Dean of the Faculty, and it's my pleasure to welcome you back to the Forum on Government and Public Policy. As I know, yeah, exactly. It's worth clapping for, right? As you know, some of you are well aware, this is a long and really impressive tradition at Flagler College, right, where we have been fortunate to bring really a lot of important and prominent speakers like our speaker this evening to campus and to kind of engage with students and to engage with the community. And like so much else, it was lost, right, or at least put on hold as a consequence of the pandemic that has, of course, ravaged the nation and the world since March of 2020, or even before that, right? And so to me, it's real special, and for me, it's a privilege to be able to host this evening's event. I would also like to just draw attention and offer a word of thanks to Jim Tetman, who is the director, right, of the Forum, because his efforts have sustained it over a number of years, but critically during the pandemic, where we were able, of course, to do some events on Zoom, but then also to kind of get us to re-engage. And this is the first on campus of what I am confident will be, a series of events this year and going forward. The Forum, as many of you know, is sponsored, right? And I would like to recognize and thank our sponsors, the Casa Monica and Leonard's, right, for the work that they do to provide support to this important endeavor. I would also be remiss if I did not thank Stephanie Burgess and her team, people who do all the event planning at the college, and this evening is no different. And these things are not easy to plan, and not easy to plan particularly during the circumstances that we now face, and I want to just thank them. But with that, what I'd like to do is move on to our speaker. Actually, one thing quick, your things will have a sheet of paper in them, right? So we will have a section at the end for questions from the audience, and what we invite you to do is just to write a question down, and they'll be collected, and then there'll be a conversation where our speaker will have the opportunity to engage a little bit with the audience and answer your questions. So with that, what I would like to do is introduce our speaker, Nora Super. Nora is a highly respected thinker, frequent speaker, and prolific writer on healthcare and longevity and the social and economic impact of the world's aging population. She is the senior director of the Millikan Institute Center for the Future of Aging and the executive director of the Millikan Institute Alliance to Improve Dementia Care. Launched in 2021, the Alliance seeks to transform and improve the complex health and long-term care systems that people at risk for and living with dementia must navigate. As is known by all too many of us, this is a significant challenge for families, for the nation that is getting worse. 16% of America's population is over the age of 65. In Florida, the percentage is 1 in 5. Roughly 1 of every 3 seniors will die from Alzheimer's or with dementia, more than the deaths of prostate cancer and breast cancer combined. In her work, Super has focused on these issues. She served the Obama administration from 2014 to 2016 as the executive director of the White House Conference on Aging. There, she received wide recognition for her nationwide efforts to improve the lives of older Americans. She has held leadership roles in the United States Department of Health and Human Services, at AARP, Kaiser Permanente, and the National Association of Area Agencies on Aging. She graduated from Tulane University, received her master's degree from George Washington University. Her public lecture this evening is titled, 3 Trends Shaping the Politics of Aging. Will you please join me in welcoming Nora Super. Nora.
Thank you so much, and thank you all for coming out tonight to talk. I've had a full day talking to many students and others on campus today, and it's great to see a little age diversity from what we had earlier. I like to say I've worked in the aging field for a while, and I say, you know, all of us are aging. Some of us just have more experience than others. So. When Jim invited me to speak, I had written a piece. I told him I had written a piece right in March 1990 for the Gerontological Society of America on 3 trends shaping the politics of aging. Now, a lot has changed since March 2020. So they came back to me and asked me if I could update it based on 2 changes that had happened that have significantly changed the politics of aging. One, the biggest one, of course, is the pandemic and how COVID has changed the way people think about older adults in our country, but also the election of Joe Biden and the changes that some of the issues that are being discussed in Congress now because of a change in leadership. So, but then since that time, I also, let me show you, also decided to talk about 6 trends. Jim teased me that that's inflation, but you know, as a person writing for a journal, they give you a word count that you have to keep, and of course you're always limited in time for how much time you have to spend on it. But this time I had no word count, and I promise I won't speak all night, but I can speak about 6 trends instead of 3. So just a little bit about the Center for the Future of Aging, where I work. The Milken Institute is a global organization. We have offices where headquarters are in Santa Monica, California. We have offices in Washington, D.C., where I'm based, New York City, and London, Abu Dhabi, and Asia in Singapore. And what's been so fascinating about this is I'm able to really study aging across the continents and really see different cultural attitudes to aging and different government policies towards the older adults that live in various countries. We really focus on 2 primary areas at the Center for the Future of Aging, healthy longevity and financial wellness. And we believe that both of these are interrelated, and you'll find that out more as I speak about the connection to your health based on how much wealth you have and how they're very strongly correlated. So, as Art mentioned, I am also launched the Milken Institute Alliance to Improve Dementia Care, and I'll touch on that a little bit about the threat of Alzheimer's disease and related dementias to the older populations all across the world. But also we're looking at new advances in tech-enabled health and home care opportunities there, social engagement strategies, noting that social isolation and loneliness is really a health risk for many older adults. And then with financial wellness, we're trying to rethink retirement. What does it mean to retire? And as I told some students earlier today, you know, people born today are expected to live to 100. When Social Security and Medicare were put into place in 1965, people were expected to live to 67, 68. So we really only anticipated that those programs would support people for 3 or 4 years. Now, on average, people live to their late 70s, and the longer you live, the higher your life expectancy. So there's a higher life expectancy once you hit 65. That means you've survived through all the things that could have killed you until you got to 65, so you're likely to live a little longer. But as we see some of those projections, we know that we need to rethink the whole perspective of retirement. As we look at that, if people are living to 80 or 90, then they're living 20, 30 years past the traditional retirement age. And so as we think about work and living longer and the finances that we need to do that, there's sort of a rethinking of what that means. The math really doesn't add up to think that you could work for 40 years and then support yourself for 30 more years if you're not working. So that's something, I won't talk that much about that today, but it's a subject that we're really looking at, thinking about retirement. And long-term care financing and delivery is also a major area that I study, because that's often a risk to retirement security that many people don't think about if they need long-term care. It's not covered by Medicare as many people think it is, and really most of it is paid out of people's pockets. So I'll touch on that a little bit. This is just a graph that shows you the aging nation that we have, and on it, it shows that for the first time in history, in 2035, we'll have more older adults than children. in the U.S. And you'll see the census data from 1960 and as they project into 2060. So we move from a pyramid to a pillar. So rather than having much more young people moving up to fewer and fewer old people, we have sort of a bulge where there's just as many, if not more, older people than young people. And that has a lot of impact on our politics and the policy that we have in the U.S. So for this talk, I'm going to focus on 6 trends, as I mentioned. The first being federal spending on older adults will rise over the next decade, and I think that will influence politics a great deal. But we do see that historic gains in life expectancy have stalled. The number of caregivers is shrinking as the need for care explodes. Migration trends are changing. More older adults are working longer, at least they were before the pandemic. And technology is disrupting the future of aging. So I'll probably spend the most time on the first trend because I think that will have the most influence on politics. Federal spending on older adults will rise over the next decade. When I first moved to Washington in the 1990s, everybody was talking about the deficit, and they put people in, and would talk about when Social Security would be depleted, when the Medicare Trust Fund would be depleted, and we had the budget hawks, and there were Democrats and Republicans that were budget hawks that would think about how can we reduce the deficit? We can't have this much at risk for these so-called entitlement programs. So that was a big topic of discussion. But lately it hasn't been. I think but as we look at these figures, what we can tell is that these programs, Social Security and Medicare, will take up a larger and larger share of federal spending. Right now, it's 7.9% of gross domestic product, and it's scheduled to go to nearly 10% in 2029, which represents 2/3 of mandatory non-defense federal spending. So how many of you have heard of the Congressional Budget Office? Great. So the Congressional Budget Office has a great deal of influence on our politics. I have a master's in public administration. My husband's an economist, and the economists have been winning in terms of the influence we have on government in a focus on numbers, that people want them to crunch the numbers to say, how much will this cost? Again, I'm married to an economist. I'm not one myself, but they're based on economic models and a lot of assumptions. They won't necessarily meet those assumptions, but sometimes politicians hide behind the numbers so they don't have to really make decisions, is what we really emphasized in public policy school. Of sometimes it takes leaders to convince people what they should be spending their money on. But the Congressional Budget Office has a great deal of influence because they determine how much they project things will cost. And people, as we're seeing the current debate happening right now in Congress, many elected representatives will really base their vote on what numbers the congressional budget comes up with. I did want to note that the reason why we see this federal spending isn't because the Social Security benefits are so great. In fact, they're really not compared to other countries. The benefits are really considered modest. The average Social Security retirement benefit is $1,475 per month, or roughly $17,700 a year. So in other countries, for example, Netherlands and Turkey, they replace people's wages 100%. And then in other countries in the OECD, they replace it around 63%. In Europe, it's around 71%. In the US, we replace the wages at about 49% for Social Security. So people's living wage goes down a great deal if they have to depend solely on Social Security. That being said, we haven't seen much attention to Social Security reform in quite some time. This is a picture of FDR when he signed the Social Security into law and Medicare in 1965. And But since that time, we have had debates. We had a major one back in the 80s with Senator Patrick Moynihan that led some discussions about raising the Social Security age and ways that we could change benefits. But since that time, we really haven't talked about it at a national level. President George W. Bush did bring it up in the 1990s, tried to was he president in the 2000s? That's what I was thinking. That sounds wrong to me. But he did bring it up in trying to privatize parts of Social Security, and that was met with outrage from many older Americans that didn't want that to happen. And so since then, it really hasn't become a national priority. Now, it used to be that the Republicans and Democrats sort of went on different lines to do this, how they would reform Social Security. Republicans would focus on benefit reductions, raising the retirement age, for example, and Democrats tend to focus on increasing the taxes that are paid into the system. But Donald Trump really changed that in terms of being the first Republican to really say that Social Security is off limits. We're not going to touch that. And I think, again, this is demonstrative of the politics of aging and the fact that older Americans have a lot of clout in our election because there's so many of them, and people that are older tend to vote much more than people who are younger. And so they have an influence on how these policies are taken. And right now, President Biden campaigned on Social Security, but he hasn't really addressed it since he's been president. And I told the classes that I talked to earlier, when I was at the White House, I traveled all around the country. And President Obama was really insistent that I went to red states and blue states to talk about those messages. And sometimes I thought I would get a bad reception if I went into states that voted primarily Republican. But it really wasn't the case. In states like Florida and Arizona, for example, there's so many older Americans that they're very receptive to a lot of these messages. It was when I went to Seattle, Washington, that I actually was met with protest and signs. And what I remember the most and won't forget is their sign said, "Scrap the tax, scrap the cap, scrap the cap." And I didn't know what that meant. Do any of you all know what that means? Okay. Someone does back there. Good. So our Social Security benefits, as you probably know, are capped at a certain income level. It's about $142,800 right now. So once you earn that much money, you're no longer taxed on your income for Social Security. Scrap the cap is people that really are trying to take that away so that wealthier individuals help pay into Social Security so to deal with the deficit more. Lately, there have been some discussions about not completely scrapping it, but raising it to for those earning $400,000 and up, so that you would have to pay taxes if you earn more than that. So, but again, these things haven't really gotten a lot of attention. I suspect they will in future years because of the ongoing pressure on the federal budget. And, you know, because these Social Security and Medicare are considered mandatory spending and that these are entitlement benefits that have to be paid out by the federal government, it means that discretionary funds are squeezed. So they have to make decisions about things like education and environment and other things that younger populations might be more interested in. The other one that I wanted to talk about was Medicare expansion and cost growth, and that continues to grow too, primarily because we just have way more people in Medicare than we did, and as I mentioned, they're living longer than we anticipated originally when the programs were started. But you know, Medicare is the largest single purchaser of personal health care in the U.S. So if this looks at the out-of-pocket spending that has gone on, if you all have been following the debate in Congress, there were proposals to add vision, hearing, and dental benefits to Medicare. Those are benefits that aren't currently covered, and then, but they're very expensive if they're to be covered. So now now their hearing is still in, but if you watch this on a daily basis, it's in, it's out. We'll see what actually gets put forward to the Senate, and then the Senate will also take things out and what eventually gets to the president. I don't anticipate that these benefits will be added just because they're looking for ways to really reduce the costs, but it definitely, I could do a whole talk on how these benefits really help people live longer and better and healthier lives, and the fact that they're not covered can end up costing the system more. Our system was set up, the healthcare system, it's really a, the expression penny wise and pound foolish. It's very much focused on not providing preventive benefits, things that could save money in the long run, and then we end up spending a whole lot of money on really costly care rather than on things that could keep people healthy over time. I did want to touch on Alzheimer's disease, as we did since I've studied this. My dad and his 3 siblings all had Alzheimer's disease, so it impacted my family a great deal. I think that one of the things that we know now is that we have more people dying from Alzheimer's disease than heart disease. And this is, again, due to public health advancements, modern medicine. People are surviving cancer now. People are surviving heart disease. That's the good news. The bad news is it means you might die of Alzheimer's disease. There's a debate among a lot of women gynecologists now and other neuroscientists about women should have replacement hormones or not. So once they discovered it could cause breast cancer, most OBGYNs said, don't take the hormones for premenopause because you could get breast cancer. Now they're saying when you don't take the hormones, you increase your risk for dementia. And so, if as a woman, if you have to choose between breast cancer and dementia, most people would choose breast cancer because you can survive it now. So it raises a bunch of these questions about, how do we want to live and how do we want to die, given all of the advances that we're having. So this just shows the prevalence by sex, age, race, and ethnicity. So how many people think that men are more likely to get Alzheimer's than women? How many people think women are more likely to get Alzheimer's? So the women are 2/3 of the Alzheimer's population. And some of this does have to do with the fact that women live longer, but that's just a small part of it. It's also things that I talked about, differences in the brain that we're discovering about women's brains and men's brains. Up until the 2000s, actually, we didn't really even study women in clinical trials, National Institute on Health clinical trials. It wasn't until we had an NIH director who was a woman who said, we really need to be looking at the impacts of this on women as well. Now we're finding that it's the same with diverse populations, that most of the studies that are done in this country, in fact the world, are on people of Western European descent. So many of the things that we study, we don't know how they might affect an Asian person or a Black person or Hispanic person. But this just shows the prevalence of, by ethnicity, Asian and Pacific Islanders had the lowest prevalence of Alzheimer's disease, followed by American Indians and Alaska Natives, non-Hispanic whites, then Hispanics and Blacks. And at age 85, over 43% of Blacks and 40% of Hispanics have the greatest estimated burden of disease due to Alzheimer's. For white Americans, it's about 1/3 of people over the age 85 have dementia. Some people think it's a lot higher than that. We did a big survey with AARP where we asked questions about the stigma of Alzheimer's disease and asked people why they feared it and what they thought. And most people thought it was an inevitable part of aging. It's really not. It's not a normal part of aging. And I could do a whole talk on that too, but really there's significant differences between normal, forget your keys somewhere, can't remember somebody's name, versus Alzheimer's disease or dementia, where you can't remember how to get to the grocery store or places that you used to go to frequently. So many differences there. As Jim said, We started the Alliance to Improve Dementia Care, and if you're interested in that, you can go to our website, but it really is me recognizing through my public policy work that, my dad was a doctor, my sister's a health administrator, hospital administrator, I'm a health policy wonk, and even with that, the way his care, and the way he was treated in hospitals and by doctors was really pretty bad. And we looked at that experience and said, just imagine if English was your second language, or if you didn't, if you had been discriminated against through your life anyway, the chances that you're really going to be treated with respect when you have Alzheimer's is low. So that's one of the primary missions of what we try to do there. Okay, so I'm going to go to trend 2, and I promise I won't spend as much time in the rest of the trends. This is an unfortunate fact that happened as a result of COVID. So, as I mentioned, people were living longer thanks to medical and public health advancements over the last century. But due to the pandemic, overall life expectancy saw the steepest decline from 2019 to 2020. Overall, life expectancy fell by a year and a half. Hispanic Americans experienced the most significant decline in life expectancy, 3 years, and Black Americans experienced a decrease of 2.9 years. White Americans lost 1.2 years in life expectancy. I'm sure all of us read the news about how COVID-19 really did reveal deep racial and ethnic inequities in access to health care in our country. And the pandemic is largely responsible for this precipitous deaths, although we did see more what we call deaths of despair, so either by suicide or people that died of drug or alcohol addiction during the pandemic. But we expect the life expectancy to continue to grow, but probably in the Hispanic and Black communities, it will last for several years. As a result, you see policymakers are much more interested in health equity now and talk about these issues. Some phrases and things that we've had in that have been in the discipline of public health for a long time are suddenly household words, although Jim wasn't aware of the phrase of social determinants of health. Has anybody here heard of that? Social determinants of health. We've got one. So this is the idea that underlying socioeconomic conditions really affect how healthy you are. So, and this holds true for many chronic diseases, whether you have hypertension or diabetes or dementia. And it's the idea that, if you don't have stable housing, for example, you are less likely to be healthy because you're having to move all the time. You may be afraid of how you're going to pay your rent. You may be evicted. And so that affects your stress levels and your health, et cetera. Same with food insecurity, whether or not you have access to healthy foods, whether or not you can afford healthy foods. So this is something that we're studying more about, how we address these social determinants of health that can help people be healthier and prevent a lot of disease. So I just wanted to show this. As I was doing research for this, found some really startling statistics that show it's not just your race and ethnicity that determine your life expectancy, and it's not whether or not exactly where you live, although just your zip code can really determine how long you might live. And so Chicago actually has the largest disparity in life expectancy, showing a 30-year gap between Streeterville and Englewood neighborhoods there. And in New York, if you are in East Harlem, you can expect to live to about 71. In the Upper East Side, to about 90. In Houston, it's 66 versus 87 years, just, getting off at a different turn on the interstate. So it's not to say that you get in your car and you move to the next exit and you move there and you're going to live 30 more years. It's really much more that what got you into these nicer neighborhoods determine how long you're going to live. So you have a higher income, you're likely to have more education, you're likely to have access to health care, healthy foods, et cetera. If you live in a very low income, you're likely to not have all of those things, which are going to influence how long you're able to live. Okay, this trend has been going on for a long time, and I've been in this field for about 30 years now and been working on long-term care and the fact that we're not going to have enough caregivers for that long. And it's like banging your head against the wall. Nobody listens, nobody listens. And it's like, this is coming, nobody listens. Well, it's here. And they're sort of listening, but not really, because it's a really tough problem to fix. In 2010, there were 7.1 potential family caregivers for every person aged 80 plus. By 2030, we think this will be reduced to 4 to 1. And this is based on a lot of factors. Women are having fewer children than they did before. Family size is just a lot smaller than it was. I think that we see that happening there for a lot. I'm trying to see, I had some data on fertility that I don't see here, so if I get it wrong, forgive me, but I know that on average today women are having, I think it's 1.64 children, which doesn't replace, we're not replacing ourselves anymore. That's a term that we use called the replacement ratio, where, you'll see charts that show the number of workers to the number of retirees. And it used to be we had an abundance of workers, very few retirees. Now we have more retirees, and we're getting smaller and smaller in terms of family size. And, this really has had an impact on the ability of people, also people move far away from where they used to live. People used to live in the same place so they could take care of their older parents or relatives. Now we're seeing that they don't have that ability anymore. So this is really impacting how people are thinking about this. So a research assistant on my team put together some of these slides for me, and she found this one just to show me that we've been debating this issue since 1919. We haven't made much progress on the issue of paid leave, but I think that right now it is being discussed because the pandemic did show that if people don't have child care and if they don't have elder care, they can't work often. And because those things were both in demand during the pandemic, a lot of women have dropped out of the workforce because of this. And it's a vicious cycle for a lot of women because the men will often earn more, and so then when one has to decide who's going to take care of mom or the mother-in-law, it's usually the woman because she makes less money, so it makes more economic sense to do that. But then her overall earnings are lower, and then that hurts her economically as she gets older. So there are proposals out there that would give people, not just women, but anybody who's a family caregiver, credit for their time working, so you don't lose Social Security benefits if you take time out to care for that. And right now in Congress, they're debating whether or not we'll have paid family leave. We're the only developed country in the world that doesn't have paid family leave. Right now, all we have is a federal program for family and medical leave, but it's unpaid. So you're guaranteed that you can come back to your job, but you won't get paid while you're gone. A lot of people don't realize that. And especially if you're an hourly worker or in the gig economy, this is happening more and more. People are not getting employee benefits at all, and so they get no pay time off after they have a baby, or if they have to care for a loved one with a serious illness. So there's been a lot of political support for this. In the earlier class, I talked a lot about who's in Congress, I think, because and I'm not trying to be hard on older white men. I'm married to an older white man. I love white men, but they still dominate Congress, and they tend to be much older and had more traditional families where their wife raised the kids while they had their career. And so the world has really changed a lot, and the way that young people think about their careers and caregiving. And I think the fact that they're getting so many people calling and say, this is really essential, we really need this. We'll see. President Biden first put in for 12 weeks, now it's down to 4 weeks, but really every other country in the world has much, much longer paid leave for when people have a baby or take time off to care for someone with a serious illness. We'll see if it gets passed this year. But we're also seeing, in terms of the politics of aging, changing in the past 2 years, really more support for the long-term care workforce as people have had trouble finding people to help care for them. I have a friend who, both of her parents have Parkinson's disease. She's an only child, and so she had to move back in with her parents. Even though she's married, she moved back in with her parents for about 2 years. Both of her parents have now passed. And finding people to, if she had a business trip, for example, she had to find people that would show up and stay with her parents for the whole weekend. And that was really hard to do and really, really expensive. And a lot of people just don't think about that. And it's hard to find workers here. So the long-term care workforce, unfortunately, has not been valued in the past, mainly because people see it as a woman's job, and primarily jobs performed by minorities, which have typically been discriminated against in our country. So the average wage for a home care worker is about $11.25. A lot of people can go work at McDonald's and make more money than they do caring for people in their homes. And, you know, I think it's really kind of a statement of how much we value older adults in our community and how we think about caring for elders. So as I mentioned, we do work at the Milken Institute across the world, and you see the Asian cultures are much more reverent towards older adults. They see them as wise and people to be cared for. In India, I have several colleagues whose parents are from India. They really hover around and take care of their elderly. They don't want them to know. They keep diagnosis from them, which is kind of weird, but you know, there's like a cultural thing of like, you don't tell them what's wrong with them, you just take care of them. So it's almost a little bit infantiling these folks, but they do care for them. In the US, nobody wants to go into aging, and we've really been working hard to attract new people to think this is an interesting, exciting field, but it's been hard. Caregiving is a challenge that will continue to be a challenge for all the reasons why I've left. So I like this Rosalind Carter quote, just as a way to think about caregiving, where she said there are only 4 kinds of people in the world: those who've been caregivers, those who are currently caregivers, those who will be caregivers, and those who will need caregivers. So that really helps us think about it. The 4th trend is really how migration patterns may be changing. So when I first wrote this paper, I was really looking at which states have the largest percentage of older adults. Of course, Florida is really high, as the dean said. It's 20.9% of the population in Florida is over the age of 65. The other 2 states with large populations are California and Texas, but that's not surprising because they're just the largest states in the country, so they have huge populations there. But what you see, if you look at this, is places like Arizona, New Mexico that have good weather. They tend to attract older adults. But then in Florida, of course, South Carolina. If you look up the East Coast, though, you'll see all the way to Maine, West Virginia, Pennsylvania. These are places that have really lost a lot of their younger populations, and the older people are left there without people to really care for them or work for them. So these states are really working on things to attract younger workers, like reducing or eliminating student debt, for example, or giving people a bonus if they'll come live there, or free housing, just things that, and I think we'll see more and more of that as we see these migration patterns of trying to find people. The other slide is from Bloomberg News, where they had a piece on more Americans are leaving cities, but don't call it an urban exodus. They called it in this paper more of an urban shuffle. And I'm a person that signifies that, and we're seeing that across that, where I was living in the Washington, D.C. area most of my professional life. But during the pandemic, when we could start working wherever, my husband and I started thinking about it and looking at downsizing. You could get so much more for your money in New Orleans, which is my hometown, than you could in Washington, D.C. So a lot of people are moving to smaller cities, places that are more affordable, and so you will see some migrations. New York City is a great example where a lot of people felt so like had very little room in their small apartments and are now moving out to the suburbs. So we're seeing that suburban migration too. We also see a lot of ageism. I challenge the students to really think about ageism that we see in the media and in advertisements that you see that often portray older adults as frail or unable to care for themselves. I mentioned to the students, I just saw the James Bond movie. How many of you have seen the new James Bond movie? A couple. So I was astounded because Daniel Craig, who's, a good-looking guy, but he's with a woman who's clearly 30 years younger than him as the love interest. And you see that in these movies all the time. The man can continue to be the star of the show, even if he's old and gray, like George Clooney. He looks pretty good, in his late 50s. But the women, we don't really see George Clooney paired with someone his age. It's generally someone much younger. We're seeing a little bit of changes in Hollywood as women have more income to spend and want to see movies that reflect themselves. But it's not changing that much. So I, really encourage people. You will see on Netflix and stuff, there are a lot more shows. There's that Michael Douglas show. Frank and Gracie and Grace and Frankie, I said that the wrong way, that are really showing older women and good roles, but it's not, and that reflects how our society thinks about aging and what we see. In terms of trends that we're looking at in migration patterns, we see that younger adults were more likely to move during the pandemic. The Wall Street Journal talked about, what they call the boomerang generation, and these are people that are moving back in with their parents because they can't afford to live on their own. In March 2020, a company called Qualtrics did a survey of 4,000 people across the United States, the UK, Ireland, Australia, and New Zealand, and found that younger workers were much more likely to move away during the pandemic, so the Gen Zers. 16% of millennials reported changing location, 9% of Gen X, that's people born between 1965 and 1980, and then 6% of baby boomers. So the younger you are, the more likely you are to move, and this is often because people don't have as many responsibilities and aren't as tied to their communities. But we're also seeing an increase in multi-generational living since the pandemic. Seeing people, this is National Association of Realtors data showing people that are asking to live in multi-generational households. And this has been a cultural thing for a long time. People of Asian descent, people of Latin descent, tend to all live together. But some of it's economic and some of it's just cultural, that they expect that, someone will take care of grandma if she gets dementia, or grandma will take care of the kids before they can go to school. And we saw a lot more of that during the pandemic, where working parents couldn't work because they didn't have childcare. So a lot of times the grandparents would be there taking care of the kids all the day. They remembered how exhausting it is. So most of my friends who are doing that were really glad when they get a day off. But also the reverse of people worried about their parents, especially because there was so much emphasis on isolation and loneliness. The fifth trend that I'm going to note is that older adults were working longer pre-COVID for all the reasons that I said. We're healthier, we feel good. People, a lot of people have trouble doing away with their identity at work and aren't really ready to retire. If you work longer, you're going to have more in your Social Security benefits. Some people just can't afford not to work. They really need the money. But during the pandemic, we saw really a decline in the employment rate for older adults, where it dropped nearly 5%, and it's less than 2% among younger workers, and it was really predominant for lower income earning workers and Black, Hispanic, and Asian older workers. They were more than twice as likely to involuntarily retire during the pandemic than higher earning white older workers. And, oftentimes it's because they were afraid, to work in retail, that they might get COVID, that their jobs were hard and they weren't getting paid much. There are a lot of things that went into this, but so we may see us go backwards in terms of getting older people to work more, which is what all of these nations in Asia, in Europe, and the U.S. Really need more older people in the workforce to help pay for some of the benefits that we have. And my final trend is how technology will really continue to change the future of aging. So many people started doing telehealth visits for the first time. Medicare allowed people to cover that. And there used to be a lot of reluctance, both on older adults' parts and physicians' parts. But when the pandemic hit and you really couldn't get in to see your doctor, then people said, okay, I'll try it. And then they found it was much more convenient. Like, I don't have to get dressed. I don't have to go downtown. I don't have to pay for parking. I don't have to sit around and wait. The doctor's actually there. And so more and more people are adapting that. We're seeing some of this go back, but we're also seeing technologies that allow people to that really do some cool stuff. I mean, they're, Alexa and some of those tools that are in the house, they do what we call passive technologies, where they can tell whether your temperature has gone up or what your heart rate is. We were telling stories today at lunch about people that we know who discovered they were having a heart attack because of their Apple Watch, and it kept beeping and beeping. I was saying how I have a friend who was in his 50s, and he thought something was wrong with his Apple Watch, and he, was like, why does this thing keep beeping? And he called Apple, and they said, sir, you need to go to the emergency room, and he was having a heart attack. So, I think that we'll see that technology really does have the ability to transform lives, but this will also create some inequities in people that are, able to purchase the latest technology. Access to broadband. People in rural communities are at a disadvantage often because of this. Recent ARP data shows that only 62% of U.S. older adults 70 and older use a smartphone, and 34% of Medicare beneficiaries living below the federal poverty level report no internet usage at all. So we're seeing now looking at access to Wi-Fi as being a social determinant of health. That certainly affected a lot of kids who had to be home for school. If they didn't have access to Wi-Fi, they got zero education, even though having it there. And now if we rely more on technology to be able to interact with your physician, that could create more inequities. But again, it can expand it. In a rural community, it could be really wonderful to be able to see a specialist that you wouldn't have access to, that you can have through your computer. Again, I work with a lot of people living with dementia and their caregivers, and we had a woman who lives in Macon, Georgia, talk about how she had to drive to Atlanta every time she had a doctor's appointment, and she has cognitive decline, so she gets confused about when her appointment is, when she should be there. She'd always have to have someone drive. Sometimes she'd drive there and she wouldn't have an appointment, and they'd have to turn around and go back. Now she has, reminders that tell her, today you have an appointment, go to your computer right now, and then she can go, and they've done that. There's another health plan now that does what they call the Geek Squad for their older adults that are now doing technology, where they actually send people into older adults' homes to teach them how the technology works so they can interact with the healthcare system. And we'll see more and more of this. We met with some business students today, some people that were interested in human resources and things, and I wanted to leave them on a very positive note that there's a longevity economy out there, and we're trying to encourage people that there are a lot of jobs in working with older adults, and older adults actually have more disposable income than younger adults, so they're more likely to spend money. The problem is a lot of products aren't designed for them, and so really getting some entrepreneurs and others to look at this as an opportunity to produce products for our growing aging population will really benefit us. So this just is a recap, and then we're happy to I hope people have written down questions, and I hope I've sparked some interest here. But these were the 6 trends that we went through today, and I'm sure if you let me, I could come up with 6 more, but these are the 6 that I thought were most interesting to bring up. And that's just a slide of all the publications we do at the Center for the Future of Aging, if you're ever interested in that. And I'm done.
Thank you, Nora. You get to relax a little bit.
Okay.
I thank you very, very much. This is terrific. Loads of information. Let me invite Professor Tara Raldiris to the stage along with her student, Donna. Donna, you're going to have to introduce yourself when you get up here. Nora, I wonder, one of the great issues that we face, of course, is having sufficient caregivers. You paint sort of a discouraging picture of that. Have there been any tools or any devices that have been successful in encouraging people to take up this important task of caring for our elderly?
Well, I think, oh, sorry, I need my mic, right? Okay. I think we are seeing technology helping. A lot of people have looked, at robots that are helping with some tasks that it's hard, that people don't want to do. I'm sure you all have seen the commercials of the vacuum cleaners that go around your house. Well, they're coming up with all kinds of tools like that will do things that actually help people. One of the biggest risks to caregivers is the physical burden that it places on people. Often spouses taking care of a spouse that's much heavier than they are and having to help lift them to get in and out of their chair. There are things that will, assist you to lift people and lower them and assist with those types of things. So we're making progress, not as much, and right now it's too expensive. There are people working on sort of reducing the cost of these types of assistive technologies. Hearing aids are a good example. We're really getting to the point where you can get over-the-counter hearing aids. They're not as good as the ones you might purchase or get prescribed from a doctor, but they help. And it didn't used to be that they would help at all, and that really helps people live much better as they age.
Good. Professor, go ahead. Press that.
Is it on? Okay. So my background is psychology, and I teach health psychology here as well as psych of aging. So my perspective on this is a little bit different. I'm obviously not kind of in the policy arena. But one of the things that we cover a lot in my health psychology course is this concern of a lot of people know what they need to do to promote healthy aging, but they don't necessarily do it. And now part of that could be they choose not to do it, but a lot of it has to do with those different types of barriers and maybe lack of access to care, or they don't have childcare, so they don't have the time to, engage in whatever healthy activities they should be engaging in. And you were kind of mentioning how our healthcare system is not very proactive. And I guess I'm wondering if you're kind of familiar with any ideas or inklings of policies that are in place to kind of promote people to actually be engaging in these healthy behaviors earlier on in life, so that we're not actually dealing with more of a kind of massive concern once people have hit older adulthood.
Yeah, that's a great question, and because I'm a policy wonk, I'll go back to some of what I said earlier about the budget people really running what happens in government, and also in the private sector. So in government, you typically have to do things within a 5-year window. It's very hard to demonstrate that something that you do preventative is going to have a return on your investment within 5 years, it's usually you have to do these healthy living things over a point in time. One thing that I worked on, the diabetes prevention program, where it was a simple program. The YMCA really was set up, and people would go for diabetes prevention, which was really helping people lose 10% of their body weight, which helps you really severely reduce your diabetes. And it was simple eating habits and walking on a treadmill. We had basically, the President of the United States had to get involved to twist arms of the Office of Management and Budget to say this will save money, even though they would never say it's really going to save money. But instead, we plow all this money into diabetes drugs and other things that happen to people. So it's really hard to change the incentives and the thought. Plus, there's not a big industry promoting prevention. There's a huge pharmaceutical industry that really influences a lot of what gets funded. So I think those things happen. There are more emphasis on prevention, I think. We do it in brain health all the time. When people ask me, what's the best thing I can do for my brain health, I say, move. Yeah. Physical exercise. Best thing you can do for any ailment you have is move. But there are a lot of, lowering your hypertension, huge risk factor for dementia. And many people don't see those correlations. And I think the more that we help people understand it, the more they'll do. But as I said, when you're a tired working mother and all you have is McDonald's in your neighborhood, you're going to eat McDonald's. But I think also there are peer counseling programs that really work. It's also adapting projects to teach people how to fix their favorite foods, but in a calorie-conscious way.
Would you introduce yourself, Donna, please?
Is this on? Yes. Hi, my name is Donna Skrenak. I am a senior here. I graduate in a couple of weeks. I went back to college after my children left home and entered their own education, and the house was a little too empty and quiet for me. So I am currently applying to doctoral programs in health psychology. I fell in love with her class. But she actually took my question. In your, I watched your video and I read your original article and your update, and you talked about statistics and how statistics of aging people are quite scary, and a lot of people don't want to become a statistic. And so it seems like it's more cost effective to put money, our governmental money, into promotion and prevention so that they don't become a statistic, and so that they're able to live their longevity, their more optimal, healthy life. Can you comment more on that?
Sure, and as a psychology major and looking at public health, behavior modification is one of the hardest things to change. So as Tara said, you know what you're supposed to do, but you don't do it. And a lot of people know they should exercise more, or they know they should eat less sugar, or they should do, and sometimes the messages are conflicting, right? So people go, well, I'm just not going to do any of it because it's so confusing. So I think promotional campaigns can really make a big difference. How many of you all remember C. Everett Koop and his big campaign about not smoking? That had a big difference, I think, in people realizing that smoking actually can kill you. And we saw smoking rates go down. We saw taxes on cigarettes. Example, in New York City, they tried to, just put a tax on a big gulp, and there was a huge backlash that people didn't want them to tell them what they should drink, even though sodas with sugar is a big reason why people are overweight, and if they just replace that with a diet drink or water, they could lose weight. But the U.S. society isn't ready, I think, to tax foods, and in fact it's actually more expensive to eat healthy foods. So I think that it will have to be public health campaigns and really starting to talk about, I didn't talk about it all, but the obesity epidemic is severely challenging our whole healthcare system because obesity is linked to many other diseases as well, but it's also challenging, as we talked about, the caregivers, not just the unpaid caregivers, but the people in the hospitals and the nursing homes and other, because they have really heavy people and it gives them workplace injuries, but we don't talk about it. People don't want to think about that. They don't want to think about the fact that, they really should lose weight, because we shame people who are overweight. We don't look at some of the underlying causes for that. And so I think it's hard to change behavior. But, as I said, education is also closely correlated to health, and part of it is knowing what you should do, but it's also having access to safe streets and sidewalks and other things that allow you to be active and engaged. So hopefully we'll get there, but like I said, in government it's really hard to make that case, and they have other industries coming in that stand to lose money if you don't go to the hospital, right? I mean, it's crazy to think about that, but hospitals make a lot more money if they have people in the hospitals getting really big procedures. If you make everybody healthy and they don't have to go to hospitals, they might go out of business. Now, I wouldn't mind if hospitals went out of business, but they would, so.
Go ahead, another round of questions, you two.
I was also interested, we also discussed in my health psych class talking about patient-provider communication, patient-provider interactions more broadly. And, I'm just kind of interested here in what we can do. I mean, this is partly an individual level problem, of course, kind of training physicians to be equipped to treat people compassionately and listen to them. The problem, though, is I think a lot of our insurance system, our healthcare system, doesn't really incentivize doctors to do that. And so this is one of the things that I have my students really kind of consider and think about too, is how do we fix this? Because, you know, if I were a physician, I can make that decision on an individual level, like, hey, I'm going to take the time with my patients, I truly care, but the system doesn't support that. And so I'm curious how we can fix that. I mean, one of the questions I ask my students is, how optimistic are you that this will change? That physicians will be able to engage more compassionately with their patients and spend more time with them. But if the goal is to see as many patients as possible in a day, then how much change can we possibly expect there? And I think that that's concerning when we think about health outcomes for older adults, but also kind of like intersectionality issues, you know, of race, gender, and socioeconomic status as well. I don't know if you had comment that.
Yeah, I mean, at first I would, you know, just acknowledge that the past 2 years have really been hard on health professionals. And I know that that's, you know, there's tremendous burnout, and there are a lot of suicides in the medical and health profession because it's been so difficult. So I just want to acknowledge that. We did a study looking at the people that really looks at people with dementia that go to the emergency room and they don't need to go. It's something like 70% of people go to the emergency department because their loved one doesn't know what's wrong with them, and they're worried and they think they need to go. And so there's been a movement to have geriatric emergency departments that are sort of separate from the regular department, where you have people who are trained to work with older adults to ask them questions about themselves and what they might change. And when we did some of the interviews with the nurses in the emergency department and said, you know, these people with dementia, you're like putting them in a room by themselves and they're so confused and it's a horrible experience. And they're like, you know, don't act like I don't want to help these people. Like, I'm working in a really busy emergency department. I'm doing the best we can. So again, you know, thinking about supports and ways that we can help them. So that is valued, spending time with patients. I've done a lot of work in palliative care in my career, and doctors who work in palliative care often talk to patients about end-of-life decisions. Do you still want to, want to have this surgery even though you have advanced cancer or whatever? And they spend an inordinate amount of time talking patients out of something. So their hospitals don't encourage them to do that because it's much easier to make a lot of money giving them a surgery that they're really not going to benefit from. So it's really the incentives in our health system that change that, not necessarily the medical profession. There is some things that are changing in terms of the way that they're teaching doctors, you know, really the emotional intelligence that's really important. But again, our medical school system hasn't changed. The doctors today all had to work these crazy shifts, and then they said, well, I had to do it, so you have to do it. And it was like, did you really like working 26 hours? Did you think you were delivering good medicine? And they'll say no, but they had to do it. And so they want the younger people. So I think once those attitudes start to change, we may see that.
Okay, go ahead.
Along that lines, it seems like today's day and age, they're really using a lot of technology and using a lot of texting, a lot of telehealth. And Dr. Aldiris, of course, mentioned in health psychology that they're trying to encourage relationships between doctors and physicians. Do you feel that telehealth takes away from that personal connection, that interaction between two people, rather than being behind a screen or pushing buttons?
So I think it depends. There are, now that we've moved more into telehealth, they're starting to do some educating of doctors of how to have a good session on telehealth. In the field of mental health, it's made a huge difference because a lot of people don't always feel comfortable going in to see a doctor, and they have more access to people via telehealth. There are also opportunities for people with, say, English as a second language, or they have hearing impairment, or they have vision issues that the technology can address some of those concerns. So I think it's a mixed bag. I have been a Kaiser Permanente member for most of my adult life that has had electronic health records. I love it because I can email my doctor, I can have video conferences with my doctor. They also can do things that are very supportive that you might not necessarily have in the doctor's office. So they can have maybe people that aren't doctors answer your questions much more quickly. So you don't have to wait to get in. They can give you good advice about something that you may want to know. So I'm actually optimistic about technology. I think it's the way to come. I think older adults, those of us that were born at a time where we didn't have cell phones. My kids, said to me when they were in college, I said, well, we didn't even have cell phones in college. And they said, well, how did you know what time to meet your friends? And I said, well, we looked at a clock and said, I'll see you at 6 p.m. And what if they didn't show up? It's like, we didn't need to know where they were every single minute. If they didn't get there till 7, then maybe we'd say, should we call, see if they're okay? So it's just really changed the world, but I think younger generations are so used to technology that some people even prefer that rather than face-to-face interaction, which isn't necessarily good for our society, but I think that you may see that more as people get more used to working with technology.
We have some excellent questions from the audience, so let me get into them. I am 75 and gainfully employed, but at 70, I had to start receiving my Social Security benefit and would have preferred to postpone receiving the benefits and receive a greater benefit when I did finally retire. Have there been any studies on this issue, and is there any effort to change it?
Well, first of all, good for you waiting until you're 70. A lot of people don't realize that you get the maximum benefit if you wait until you're age 70. That we've started thinking about ways to talk about that. People say normal retirement age is 65, 66, will soon be 67, rather than saying full retirement is age 70, to let people really know when people take their Social Security benefits at an earlier age, it really changes the benefit that they get. In terms of how people think about working longer, I think, it's a budget issue in terms of they feel that they need to start paying it out for people, but that certainly could, I think you're rare, and so I applaud you in saying you don't want your benefit now. But, I guess my big advice would be then invest it if you don't need it. And what I told a lot of the younger people that I met with today, early on in my career, I worked for someone who's a retirement expert who said, take the employer match. If you have the employer match, and this is what I tried to say to younger people, it's like free money. You'll never get that kind of return on investment. And I got that advice when I was 24 years old, and as a result, I have a nice little nest egg for me when I retire. And I think people need that kind of education too. And if we see people have more income and ability to work, we may see, I think over time too, as I said, people are starting to think about what does a 100-year life look like. So we'll start to see some of those changes to encourage people to work longer.
What's the situation overseas in terms of eligibility for Social Security? I mean, here you start collecting it at 67. There's some talk of raising that even more. What is in the Netherlands and Turkey, for example, when do they start getting their full benefit?
I don't know the exact age. I know in European countries it's typically young. It's like 62 to 65. And the European countries are struggling with this as well because, again, people are living much longer. And so they're encouraging people to retire early, to work longer, but they don't want to. And a lot of people say, I tell a lot of people that say, well, I want to work longer, and, everybody would want to work longer. And, I'll probably work to an older age, but I have a really intellectually stimulating job. I, work behind, a computer all day. A lot of people hate their jobs and can't wait until they retire. But I think that we can start thinking about new opportunities for people to see this third part of life as an opportunity to do something different. So.
Are there any changes afoot to allow Medicare to negotiate drug prices?
Good question.
There's more.
Unfortunately, and I tell this story, Senator Bill Nelson, who used to be the senator in Florida, was in Congress when I was a lobbyist for AARP, and he was willing to take on the drug industry. And he had a bill in Congress during the Affordable Care Act. This is when Democrats had a 60-40 majority, and I was a lobbyist, so we went around and counted all the votes. This would be to really affect the patents that pharmaceutical companies get for drugs that they put in place that, we wanted to reduce it to 7 years from 14 years. We got exactly 17 votes out of 100. And to me, it was just a big reflection of how much influence our pharmaceutical industry has on members of Congress. They give tremendously to campaigns. And I'm not down on, pharmaceuticals have changed my life in the ways they've changed many people's lives, but all other countries negotiate these things. They also negotiate. So the one good example is Aduhelm, which is was approved for Alzheimer's. It would cost $55,000 per patient. So some of these things people are starting to do, but people are very opposed to negotiation of drug price. The pharmaceutical industry, I think the statistic is there are 5 lobbyists per member of Congress. So they really have a disproportionate impact on how people vote on those issues. So I don't see it happening anytime soon, unfortunately.
How about within the regulatory system, is the $35 monthly Medicare insulin cost going to be approved?
I hope so. That's been a big debate that's been out there, people really complaining about, and I think that it's taken notice. So I think, and that could be changed, as you note, at the regulatory level. Doesn't take Congress to do it. So I think that has a strong possibility.
You mentioned mandatory non-defense spending. What is included in that, and could it become non-mandatory?
So mandatory non-defense spending is Medicare, Medicaid, Social Security, disability insurance, things that people pay payroll taxes into, that they're entitled to a benefit as a result of the taxes that they've paid into that. So the budgeteers call it mandatory because they're obligated to pay it, whereas all the discretionary spending is appropriated every year. So they vote on it every year, how much they will give to, and defense spending is also, has laws in place that require a certain amount. But the discretionary spending is things like education, the environment, housing, transportation. So all the things in the infrastructure bill, for example, those are discretionary generally. So not becoming mandatory, these are the fights that people had before, like I was saying, when people used to talk about Social Security and Medicare. There certainly have been people that say we shouldn't, we shouldn't give all this automatically to someone because they turn 65. There are people that think if you have unhealthy behaviors, you should pay more into the system, and so that you should be what some people call sin taxes, where if you're a smoker, then you should pay more. If you are obese, then you should pay more. That's some of the solutions there. There are also folks that, again, don't think that certain people over a certain income shouldn't be entitled to these benefits because they can afford to pay for it on their own. So I won't say it's going to change. I think it's more likely that the age will keep going up. There was also a proposal in Congress this year to lower the Medicare eligibility age to 60. And it was actually would be make good sense for Medicare, because the younger you are, the lower risk you have for severe health conditions. But again, people are really worried about this entitlement and the fact that the federal government would have to pay it.
What percentage of Social Security benefits go to just people with disabilities?
I don't know that off the top of my head. I know that it's hard to qualify for disability. A lot of people really complain about how long it takes to get their disability benefits, and what you have to do to prove it. You have to be completely disabled, not able to work. You have to prove you're not able to work. They also make you wait 2 years before you get Medicare. So it's a percentage of people, and I could definitely find that out for you later. Are you going to hit me in the head with that?
Yes, I am. And that's through the classes that Nora did today, I kept saying, is there good news here? How about some good news? And I realized the good news is that we have people like Nora Super out in the hustings, basically spreading a very, very important message. And haven't we been lucky tonight that she's with us? So thank you. So as a gesture of our gratitude and appreciation, we have the Flagler Lion for you. You can hit whoever you want with it. It's a very, very heavy statue here, and so I don't want to drop it because I'll probably go through the floor. But do again thank Nora Super for just a terrific evening, and Professor, thank you. Donna, thank you so much. Your questions always add a lot, so thank you. Good, thank you very much. February 17th, we're back. Lee Rainey from the Pew Research Group will be here talking about a new nationwide historic poll they're doing on politics as they look forward to 20. It's a once-a-decade poll that they do, and he'll be here to talk results with us. So thank you. Have a wonderful holiday. We'll see you in February.
Thank